So what we have seen is with the current COVID-19 pandemic is that it results in a rapid surge of utilization of beds, ventilators, and specific staff and personal protective equipment. This, of course, results in a dramatic change in all medical practices, certainly also in urological practice. And we have two key aims to fulfill. And this is, first of all, maximal protection of staff and patients, but also minimal collateral damage for patients that are still requiring urological care in these times. And to be able to do so, we need to cancel elective surgery, and we need to prioritize in our other more urgent urological or uro-oncological surgery. And this is not so easy. This has been a challenge, and that's why we tried with BVU SBU to provide some guidance. So regarding priorities, it is important that priority making depends on capacity and demand. So this means that depending on the local regional resources that you have available in your hospital and the course of the pandemic, it could change which things that can be cancelled or still be going on. There is also the question of impact on survival. So this means there are urgent uro-oncological conditions, not only oncology, but also others that need to be treated urgently, otherwise we impact on survival. And of course, this is also true for oncological diseases. And we don't want to have things like you see here in the media, that people start to worry about survival of delayed cancer surgery. Next to survival, we can also think, next to surgery, we should also think about non-surgical alternatives. And that's why I'm very happy also that this meeting is a multidisciplinary meeting with oncologists and radiotherapists. We need to take into account also the patient frailty to see if we would go on with surgery, what is the risk of the patient in the postoperative setting if he would get infected with COVID-19. And then last of all, we need to think also about the techniques of surgery that we will use to see what the need is for postoperative intensive care, length of hospital stay, and the risk of complications. So it's a very challenging choice that we have to make, and all the things that we will bring here in the next slides, and that actually not only the BVUSB has done, but a lot of societies also on a European level. This is all expert opinion. This is by no means rigid or all-encompassing. We try to give you some guides, but this is not really true guidelines or recommendations. It's a thing that we can use to guide ourselves through these difficult times. Next slide, please. So this is one of the things that I certainly used in making our scheme. This is a good website with resources about COVID-19 provided by European Urology. There are many others, but especially for urologists, you will find a lot here. Next slide, please. This is what we have made. You may have seen it through emails or social media. This is now the updated version that we have made specific for this presentation. And you will see that we have chosen for levels, for 4 stages. And we have not just said you can do it or you should postpone it. Depending, as I said, on where you are in the pandemic, and this changes sometimes very rapidly in days or 1 or 2 weeks. And also, depending on your local researchers, you will find yourself in one of these stages. And stage 1 is primer cancellation. This means that all elective things, benign things can be cancelled. Even low-risk prostate cancer can be cancelled. And then you go to more aggressive tumors that can be less easily cancelled, or also stone surgery that still has an impact that should be cancelled last. And then you have, of course, the emergencies. I will not go every detail here. You will find it afterwards as well. So this is about, thank you for those that filled in the online survey. This is what we have from responses. and this is what you see, is that most people indeed, they are not doing elective surgery anymore, except for a very few. Most are really doing high-risk cancer surgery, and we can still have some debate, like there will be questions probably about intermediate versus high-risk surgery, but this is for later. This is Flanders. If you then look to Wallonie, you see that it is more or less the same, although there is a little bit more elective surgery that was still going on, but this can be very local. I mean, not everybody answered this. Next slide, please. And this is then to see in which stage you are in one of these 4 stages that we classified. And you will see actually that here in Flanders and also in Wallonie, it is about the same. So this means that almost everybody is in stage 3. This means only doing surgery for urological conditions with severe symptoms or with aggressive oncological pathology. And even about 10 to 15% is urgent emergency only. The ERUS Society, so the European Robotic Urology Society, has made a quite similar scheme that was actually based on the one of the BVU. Also other countries like the Netherlands and Germany have followed this. I also have to admit it's not completely us who invented this. I have based, of the BVU has based ourselves on a scheme from Guy's and St. Thomas. So this is about robotics. Then if you look to uro-oncology, why did we make these decisions, or which rationale is there for yes or no postponing a certain kind of surgery? So first of all, look to bladder cancer. We know if we, and 3 months, remember 3 months is a very important time frame. We know that if we will postpone muscle-invasive bladder cancer treatment, being by cystectomy or another treatment, we will have more mortality. It is overall survival, progression-free survival that is decreased, and also more PN plus stage, higher pathological stages. The same is for TURBT. When you think about it, it's more than just a TA, superficial disease. It could be invasive. Then you have to do it because it can even be muscle invasive if you take into account the number of muscle invasion in re-TURBTs. Then the next is kidney cancer. Most of the CT1 kidney cancer, so this means less than 7 centimeters on a CT scan, can really be postponed. There will be no impact on survival if you postpone this 3 months or more. If you have T2, it's already a little bit more tricky, and certainly for T3 tumors or everything that has venous or other invasion, you have to be sure this can go very rapidly and this should still be treated. About prostate cancer, following the NCCN guidelines, most of the prostatectomies could be delayed, and certainly low risk, and they also say here intermediate risk. For high risk, I think this is still something that should go on, or there is the alternative to, maybe we have to discuss later, to give ADT upfront, so androgen deprivation therapy, and postpone your surgery or go to radiotherapy. Then for the next, we have testicular cancer should proceed. Orchiectomy is a day clinic, and post-chemotherapy or PLND is also important for survival. UTUC is the same as bladder cancer. If it is high risk or invasive, you have to proceed. Adrenal tumors, if there is, if it's more than 5 to 6 centimeters, the chance that this is a cancer and not just an adenoma is very much increased. And then we know that survival will be impacted if you do not operate immediately. For the others, if you have a pheochromocytoma, of course, this is also more or less a life-threatening disease, so it is better to proceed as well. For penile and urethral cancer, we know that this can also very rapidly progress, although we do not have really time constraints in evidence, but we know from our experience that it would be better to proceed with this surgery as well. So this was oncology. About stones. There has been this nice paper that is also in the resource center of European urology and has been made by the group of Milan. And this shows a bit what is also in these 4 schemes. So this means that if you have a non-obstructing renal stone without any symptoms, and just do nothing. If you then go to urethral stone that gets obstructing the kidney, that gives difficult symptoms, this is stage 3, last to be cancelled. And if you have impact on renal function, or you have pyelonephritis with it, then it's an emergency. And this is actually a nice guide to use. Okay, this is also a good scheme. This comes from the article of the stones, but this is a good, you can use this for every kind of surgery actually. So if you look at your patients that you scheduled for surgery, then you have to do this prioritization using all the schemes and the things that we have seen. And then still you have to see and to phone your patient a few days, best is 2 to 3 days in advance, because you will not be happy to be operating on a COVID positive patient for many reasons. And first of all, for the patient himself, because he can be in really danger if you proceed. And then also for the staff and everybody around it, and the hospital where you have a COVID positive patient in a non-COVID ward. So you call them, you ask if they have fever or symptoms of COVID. If they would have it, then these patients, if they still need to be treated as a medical emergency, they need to be treated in a dedicated OR and COVID facility. Next slide, please. Okay, so this was one of the questions also from the survey. And you see here that this is Flanders, I believe. Yes, this is Flanders. And we see that in Flanders, almost 3/4 of the patients are tested before any surgery. And this depends, of course, this will change. 1 week ago, it could have been half of that. And maybe next week, everybody will be tested. And because testing is more and more becoming available, and this could be important for the safety of everybody. Next. In Wallonie, it's still less, but as said, this could change very rapidly. Next. This has been a lot of discussion actually in the last 1 or 2 weeks. Twitter and social media were full of it, guidelines as well. Is minimal invasive surgery an increased risk, yes or no? This is the opinion of everybody who answered it. So 3 and 4 things, it has more risk. Next slide. One of the most important authorities I think that we can follow is the one of SAGES. So these are the American gastrointestinal surgery community, and they have really given good advice based on the little evidence that there is. But this has been, in my opinion, the best site where you can find information. So first of all, they say that it's very important to have personal protection, depending of course on the availability, but please do protect yourself and your staff. Then, as I've said, you have to rationalize and to prioritize. And then practical, they also advise to have testing of everybody before surgery, because then you have less risk of putting yourself and your team into danger, and also to spread the disease further on. Regarding laparoscopy, and this is why we discuss it here, there has to be said, and this is really true, there is very little evidence of the risk of minimal invasive surgery specific to COVID-19 virus. And you have to balance this risk against the proven benefits of minimal invasive surgery, being reduced length of stay, fewer complications, and less intensive care use. Anyway, if you do use laparoscopy, so it is not contraindicated. There is not a single one, I believe, that is still contraindicating it. There were some, like the Royal Association of Surgery, so from the UK, and also the American College of Surgeons. They did first, but they have now revised. So about which measures that has to be taken for preventing spread during surgery, they say please use a device to filter released CO2 and also minimize your energy settings. So again, to talk about this, this was the only publication that was in Annals of Surgery very, very recently that shows that there could be an increased risk of minimal invasive surgery. And of course, you have to balance it, as said, against the reduced need of intensive care, length of stay, and complications. About this risk, why would there be a risk? Well, there is aerosolization. And of course, this happens in any type of surgery, also in open surgery, but it is contained in the abdomen. And if you have all this surgical smoke with possible virus particles, if you would release it in a very short time, or you release it through a trocar right in your face, of course, at that moment there could be a danger. So we need to protect and have some specific things. On the other hand, before going on these tips and tricks, you have to know that it is proven for HIV, for hepatitis B, and also for HPV that it is found in surgical smoke. It's only for HPV that there has been a transmission. So this means that surgeons that inhalate smoke can be infected with HPV. It's never proven for another disease. It was only for HPV. We do not know that COVID can be found in surgical smoke. It is not known, but it is better that we, for the moment, until we know it for sure, better safe than sorry, I should say. So this means that we have personal protection for everybody, match the incisions of the port sizes so that you have as little gas leak as possible. Use low pressure pneumoperitoneum. The lower the pressure, the less risk that you will have that there is a leak. The electrosurgery settings should be as low as possible. Then you will produce less smoke. You should be cautious with ultrasonic or advanced bipolar devices because they typically produce smoke in a lower energy setting, and maybe the particles could, the virus particles could survive in these circumstances. We do not know for sure, so but be cautious. And use, for sure, this is the most important thing, you have to use a smoke evacuator. There are devices enough, and I will not specifically recommend one or another, but you will find this website where you can find several ones that has been evaluated. They all need a ULPA filter. This is the most important, an ultra low particle filter that goes at least up until 0.1. And if it is lower, 0.01, it's even better. And then you also, at the end of the operation, this is very important, look for safe desufflation of your pneumoperitoneum, and then you can use an extra filter for that. The next thing is just to show you, this is what has been known in peer-reviewed articles. Where can you find COVID-19 and which body fluids? And you will see that urine is very, very, very low. Most have almost found nothing. There has been one or two articles that found very small numbers of COVID-19 in urine. Of course, this is spontaneous, so we do not know if you will start operating in the urinary tract, if there would be more particles released, but because as you see in blood, there is already more COVID-19 present, and the most important is stool. So for all those that have that are doing urinary diversion using bowel, this is probably for urologists the most challenging surgery or risk for infection, if, and it's again said, if it would be that it is found in surgical smoke. This is comes from the NCCN guidelines, and this can give you a guide how to do your follow-up consultations for oncology. So if you see how many times that you normally see the patients, then you can try, this is adapted from their guidelines during these times to see how easily you can reschedule or postpone an oncological follow-up. Next. So I want to conclude. This is my last slide. So I think the most important thing is that we have to prioritize. We cannot do everything anymore. Solidarity is important, common sense, and protect the patient, your staff, and yourself. Thank you.
How dangerous is it to operate on a patient while he or she would be COVID positive, even without symptoms? How would that expose the team or the patient to very high risk of maybe even dying of the disease?
Okay, that's a good question. Thank you. So first thing, I think if there would be enough tests, I think they would test everybody that is now operated on, and the biggest risk is certainly for the anesthetic team because of the intubation. If we think that there could around be 10% of people that are asymptomatic, have no symptoms, this will be also about 10% and the people that we are still operating on. So if we start spreading the thing around in the teams, this could lead to fallout of big parts of teams, and also contaminate other patients in the ORs where it is known to survive for longer time. So we do not want that our hospitals become wind tunnels of COVID, as they would say.
There is another issue, but there is only very few data on it, that is that if a patient is carrier of COVID, but is still asymptomatic, so he's in the incubation period, there is some data from China showing that if you operate on patients who are carriers of COVID, who are infected without any symptoms, that 44% of those patients end up in ICU, and 20% of those patients die of the disease. So it's very, very important that everywhere, when patients are operated, that the implementation of testing patients that will stay in hospital for longer periods, certainly if they're older and at risk, or if they undergo risky surgery, those are the patients that have a really high risk of getting into major problems for themselves. But apart from that, I fully agree, Karel, with what you said, that the teams should also be protected very much, because in the end, there still needs, we still need people in the ORs to take care of urgent cases. Now, talking about urgency, we have heard a little bit of mixed message in high-risk prostate cancers. So maybe just very briefly, Karel, how safe is it to put patients on ADT when they have high-risk prostate cancer? Is there data? Can we do that? Should we not do it? And if we do it, should we include patients rather in trials, or should we just say to a patient who are high risk, now we still can operate, but maybe in 1 or 2 weeks we cannot anymore operate these patients? How safe is that? How long safely patient can be put on ADT, or should we put them on ADT, or should we just postpone treatment in high-risk prostate cancers? And what is the evidence for that?
Okay, thank you for the question. That is an important one. So I think if you can still operate them, yes or no, it depends on your local capacity and also the timing of the pandemic. So some hospitals may still have the possibility to do high-risk prostate cancer surgery. So, and then I think they should go on. If you would not, and then you think about starting ADT, the evidence behind it probably comes most from what has been seen in radiotherapy, I believe. The question would be, if you wait with a high risk for 3 months, would this alter overall survival or progression-free, even biochemical-free survival?
Well, I think this is a very pertinent question, and in a sense, I received in the chat box, I received a message from Karel Salambier, who alluded to this. There is very limited data on waiting with surgery in high-risk prostate cancer, and there is some data from Milan before all the Corona and COVID crisis. You have to know that Milan is a big center. They do 500-600 radical prostatectomies, but it's half private and it's half public. And in the private setting, they can do immediate surgery within a week or two. In the non-private setting, some people have to wait a long time before they can be allowed to have their surgery. It's undemocratic. It's not my fault, but it just gave them the opportunity to look at time delay in delaying high-risk prostate cancer and what does it change or not change in oncological outcomes. And actually, I don't even think it's published, or maybe it's published, but it's a bit sensitive information, of course, because it's comparing public and private practice. But they state you can wait up to 12 months in high-risk prostate cancer. And even within this time period, there is no overt, clear difference in outcomes in patients with high-risk prostate cancer. But we have to be very, very careful in interpreting and over-interpreting their data. But it's probable that a month, like 3-4 months of delay, even in high-risk prostate cancer, is likely still safe. And it's not known, there's no good evidence that neoadjuvant ADT is doing anything that changes in the good way the prognosis. Okay, maybe the PSA goes down, the patient is happy because the PSA goes down, but maybe at the same time, we're doing something that is not very good. Certainly in patients with high comorbidities, we have to be careful. Even a couple of months of ADT can be deleterious for those patients.